Good day everybody, I'm Blessed Elaine Ipla, and for today's video, I'm gonna be talking about electrolyte imbalances, specifically calcium imbalances, magnesium imbalances, and phosphorus imbalances. Now we will talk about magnesium.
So what is magnesium? Magnesium acts as an activator for many intercellular enzyme systems. It plays a role in carbohydrate and protein metabolism. It is vital in neuromuscular function because it acts directly on the myoneural junction, and it produces a sedative effect on the neuromuscular junction, inhibiting the release of acetylcholine, which is a neurotransmitter. Magnesium serves as a molecular stabilizer of RNA, DNA, and ribosomes. It regulates diverse biochemical reactions in the body, including protein synthesis, muscle and nerve function, blood glucose control, and blood pressure regulation. The total body magnesium content of an average adult is 25 grams, with 50 to 60% found in the bones and most of the rest in the soft tissues, and less than 1% is found in the blood serum. The normal serum magnesium levels is 1.3 to 2.3 milligrams per deciliter. Calcium and magnesium are similar in two ways. The ionized fraction is primarily involved in neuromuscular activity and other physiologic processes, and they should be evaluated in combination with albumin levels because the decreased serum albumin level can reduce the total magnesium concentration. Now, what is hypomagnesemia? Hypo meaning under, low or less. Magnes, a prefix for magnesium, and emia meaning blood. Therefore, it is termed as the low magnesium level in the blood or is less than 1.3 milligrams per deciliter. The causes include decreased intake or the prolonged fasting, the decreased dietary intake of magnesium, the decreased absorption or the malabsorptive disorders, vomiting or diarrhea, increased losses such as alcoholism and excessive sweating, and medications include the diuretics and antibiotics. The contributing factors include chronic alcoholism, hyperparathyroidism, hyperaldosteronism, diuretic phase of kidney injury, diabetic ketoacidosis, acute myocardial infarction, heart failure, and decreased serum potassium and calcium levels. And for the pathophysiology, example here is the nasogastric suction, diarrhea or fistulas. There would be an excretion of fluid, and if it is not replaced through IV infusion, it can induce hypomagnesemia. And another is the chronic alcohol abuse. There is loss of magnesium in the tissues, which could be include renal magnesium wasting, which could result to hypomagnesemia. The signs and symptoms include positive Trosu and Schwostek sign, anorexia, and hyperactive tendon reflexes. Positive Trosu is a carpopedal spasm induced by inflating a beefy cuff under systolic BP, and the Schwostek sign is a contraction of facial muscles elicited in response to light tap over the facial nerve. Then another is neuromuscular irritability, hypokalemia, insomnia, confusion, mood changes, vomiting, high BP, arrhythmias. And for the ECG, there is premature ventricular contractions, flat or inverted T waves, depressed ST segment, prolonged PR interval, and widened QRS. The complications include seizures, cardiac arrhythmias, coronary artery vasospasm, and even sudden death. The diagnostics and laboratory procedures. First is the nuclear magnetic resonance spectroscopy and ion selective electrode. Nuclear MR spectroscopy is based to determine content and purity of a sample as its molecular structure, while the ion selective electrode consists of a thin membrane across with only an attended ion which can be transported. The management. For the pharmacologic is oral magnesium salts in an oxide or gluconate form, IV solution of magnesium for patients receiving parenteral nutrition. Bolus dose of magnesium sulfate and vital signs must be assessed frequently. Calcium gluconate must be readily available. Nursing diagnosis and management. First is risk for electrolyte imbalance, hypomagnesemia related to chronic alcoholism. You have to assess the level of consciousness and neuromuscular status, monitor vital signs, cardiac rate, and rhythm, monitor intake and output, provide safety, seizure precautions, encourage to take magnesium-rich products such as green, leafy vegetables, nuts, legumes, and others. Patients should be screened for dysphagia or difficulty of swallowing. To discourage alcohol intake and administer meds as indicated. Next is imbalanced nutrition less than body requirements related to gastrointestinal malabsorption as evidenced by diarrhea. You have to ascertain healthy body weight for age and height. Consider small, frequent meals instead of 3 large meals. Offer magnesium-rich foods such as green leafy vegetables, nuts, seeds, legumes, and others. Discourage alcohol intake and encourage exercise and promote good oral hygiene. Next is risk for decreased cardiac output related to altered electrical conduction as evidenced by cardiac arrhythmia. You have to palpate pulses, noting rate, amplitude, and symmetry. Monitor vital signs. Provide quiet and calm environment. Monitor serum electrolytes. Prognosis: hypomagnesemia is generally well treated with therapy and lifestyle changes, especially dietary modifications. However, if risk factors are still present like alcoholism, poor prognosis can be presented. What is hypermagnesemia? Hyper meaning above, excess or high. Magnes, a prefix for magnesium, and emia meaning blood. Therefore, it is termed as the high magnesium level in the blood or is greater than 3.0 milligrams per deciliter. The causes: kidney injury, Addison disease, hypothermia, excessive use of magnesium-based antacids, including opioids and anticholinergics, lithium intoxication, extensive soft tissue injury or necrosis as with trauma, shock, sepsis, cardiac arrest, or severe burns. The contributing factors: excessive IV magnesium administration, adrenal insufficiency, diabetic ketoacidosis, hypothyroidism, and oliguric phase of acute kidney injury. For the pathophysiology, example here is the hypertension of pregnancy, and pregnant women with hypertension are given with magnesium sulfate, and this is to prevent seizure due to worsening preeclampsia. And there will be an increased magnesium level in the blood which may cause hypermagnesemia. The signs and symptoms include drowsiness, muscle weakness, hypoactive tendon reflexes, and flushing, hypotension, depressed respiration, diaphoresis, and for the ECG there is tachycardia to bradycardia, prolonged BR interval, and QRS, and there is peaked T waves. The complications include coma, cardiovascular complications, neurological disorders, and cardiorespiratory arrest. Diagnostics and laboratory procedures: serum magnesium level and electrocardiogram. The presentation: as creatinine decreases to less than 3.0 milliliter per minute, the serum magnesium levels increase, and for the ECG there is prolonged PR interval, tall T waves, a widened QRS, and a prolonged QT interval. The AV block may be viewed. Management: patients with severe hypermagnesemia, all parenteral and oral magnesium salts are discontinued. In emergencies, ventilatory support and IV calcium gluconate are indicated. Loop diuretics and sodium chloride or lactated Ringer solution enhances magnesium excretion. Nursing diagnosis and management. First is risk for electrolyte imbalance, hypermagnesemia related to impaired renal function secondary to kidney injury. You have to monitor vital signs, noting signs and symptoms of hypotension and shallow respirations. And do not give magnesium to patients with compromised renal function. And for the collaborative is to administer medications as prescribed.